Okay, so we're going to give people a minute or two to just filter in. Okay, so good morning, everyone, and thanks for joining us this morning at our Simon Talks webinar on harm reduction and homeless services, the rolling out of harm reduction in homeless services. This comes from, in part, an Erasmus project that ourselves and two of the organisations, the speakers, are involved in looking at developing harm reduction and developing sort of the principles of harm reduction in homeless services. So we felt it was a really good opportunity to maybe take some of the learning that we've developed in rolling out training and in kind of working together. So we thought that this webinar is kind of inspired from that work. Just to say, if you are on social media, so our Twitter handle is @SimonCommunity, and if you can join the conversation online by using the hashtag Simon Talks, which I think my colleague Gareth there will put into the chat. I'm going to speak very little today. I'm the chair, and my name is Wayne Stanley, and I'm the head of policy and communications with the Simon Communities of Ireland. And the group that we've come together at was led by Thiesen, and I'm currently vice president of Thiesen. Speaking today will be Roberto Perez Gayo, who is a researcher, social designer, and project officer at Correlation, which is the European Harm Reduction Network. The network focuses on the intersection of drug use, homelessness, gender and sexual orientation, sex work, and migration in the field of service provision, as well as social and health policy. After Roberto has finished speaking, Henrik Thiesen will speak, and Henrik has more than 25 years of experience of working in addiction medicine, health outreach and harm reduction for homeless alcohol and drug users. He has served in different primary healthcare positions, including research and management of health outreach, and is now managing a citywide low threshold health and harm reduction system in Copenhagen city, including both public and NGO institutions. Henrik is involved in work with several national and international organizations, including Street Medicine Institute, Fianza, Correlation Network, and EMCDDA. Okay, once Roberto and Henrik have done their presentations, we have my colleague Karen Feeney from Galway Simon, who is head of client services, and she brings with her 25 years of progressive experience across the social care sector. She's been dedicated to meeting the needs of marginalised people throughout her career. She's worked in community development for over 10 years in Galway and Tala. Since joining Galway Simon 12 years ago, she's played a key role in the development of services in an increasingly challenged environment. And Karen holds an MA in community development, a Bachelor's of Arts in psychodynamic psychotherapy. And Karen will be talking about the Irish experience, but also responding to the presentations of Roberto and Henrik. So with no further ado, and with thanks to you for attending, I'm going to hand over to Roberto.
Thank you so much, Wayne, and thank you actually for inviting me to contribute to this Simon Talks. I have a tiny presentation that I would like to be sharing with you. Can you see well on my screen? One of the things that I would like to be sharing with you is coming out of the project that Wayne was mentioning at the moment, together with Wayne and Simon Ireland, and also together with Norte Vida in Portugal, the ANSA, and also like with the health team, Henrik in Denmark. We are doing a project that is called Harm Reduction for Homelessness. And one of the pieces of work that we did in there is a training for service providers working in the field of homelessness or harm reduction. And out of this experience, there is like a piece of knowledge and a piece of work that I would like to be sharing with you. that actually proved to be quite interesting, and I just would like to be extending it with you. It has to do a lot with ideas of how we are framing and constructing drug use and drug users, and the different beliefs and the different views and values that we're having on this as a way of opening up possibilities for a different way of providing social and healthcare for people who use drugs and people who experience homelessness. Our perspective on substance and substance use, one of the premises that I'm having in here is that has been differentiated according to context and according to time. And also like each person perspective on drugs is shaped on how our peers, for example, our families or our friends, actually they are related to substances and the attitudes towards them, but also our professional experience with people who use drugs, the general attitudes of societies, our own experiences, the laws, the customs, political views, and attitudes to authority, among many others. These beliefs and these interpretations are understood as formulated opinions and mental views. And in my work, I've been always very much interested, particularly positioning myself as a person with an experience in provision in homelessness services and services for people who use drugs, into understanding a bit what are these views and what are these beliefs, because are completely important, having the power to shape not only the kind of services that they are providing for the communities we belong to or we work with, but also they have the capacity to establish relationship with other professionals working in the field. And also these views and these values can create a set of conditions and a series of roles and procedures through which care is enacted. One of the things is actually that these views also have the capacity to inform the models for help in the support that is offered and also the policies we are having. In here, I'm using the term framework as a way of like a series of encompassing structures or ideas that actually they are collecting together these views, and they have particular historical moments in which they have been developed. And it's a bit my intention with this is to put forward a bit of an idea of like how this understanding of drug use and working with drug users is constructed as a way of like later on to be able to open up questions of how do we want to move forward in order to be able to support better these communities. One of the first frameworks that I want to be presenting here is like the so-called moral framework. Like the moral framework holds the idea that the root cause of problematic substance use is an individual's inherent moral weakness or a lack of power. This view of drug dependence as sin is already originating as early as in the 18th century, and it was particularly popularized in the Victorian era. With this model, what we see, some of the things that still exist nowadays, is there is a dichotomy of roles that arises. On one hand, we have people who use drugs, which are normally characterized as misfits, no hopers, or in the best of the cases as objects of pity, and they assign them some sort of a role of helpless victims due to the lack of will. On the other hand, we have like the figure of the dealer, which actually is normally described as a scam or a burning or an evil menace. And normally they are assigned this role of some sort of like predator to some degree. Contemporary beliefs that still are very much into the rhetoric and discourses of like once a junkie, always a junkie, roots very much in this framework, and they suggest that nothing or much can be done to support people who use drugs, a vision which unfortunately oftentimes is internalized by people who use drugs themselves. Another framework that I want to put forward in here into how we understand drug use is through a pharmacological model, which normally is based on the belief that particular substances have the power or the attraction that is capable of overwhelming the will of the individuals, the communities, and even societies. Drug users, again, tend to be portrayed through this framework as helpless victims, but this time it is the drug and the power of its intoxication and its effects that they are to play. With this, the same with the moral view, sometimes we see that we discount a lot of a vast array of personal, interpersonal, and structural factors that they are contributing and continually influencing a person's drug use and behavior. Also, ironically, sometimes these beliefs can provide a person who has drugs, problematic relationships, within a certain particular way of escaping an idea of actually understanding better their actions and how they are relating to the drugs because the harm is put on the substance itself. In this way, it can restrain a person from gaining a deeper insight into the conditions of their relationship with drugs. Very much related with the previous two frameworks, with another one that is called a coercive framework. This model approaches substance use as a criminal issue. Operating from a supply reduction logic, this model instrumentalizes legal apparatuses such as policies, law enforcement, judicial system, and ultimately prisons in an attempt to control substance use and substance themselves. Criminalizing policies like the war on drugs, prohibition, or punishment are rendered the central tools through which to interact with drug use and drug users. As a result, drug users are characterized as criminals based on the assumption that drug use is moral wrong and the substance so-called drugs are inherently bad for people and therefore have to be banned for society. Therefore, also there is in here another element that is quite important, that actually this framework puts forward an idea that drug consumption in itself also is leading to not drug crime that must be also punished and prevented through the tackling of drug use. More contemporarily, we have been witnessing a change of paradigm in which the relationship to substance and people who use drugs are approached through a medical model. The basic assumption in here is that substance dependence is a disease or a pathology. And in this way, the medical disease model is assuming that change and health is possible, but is only possible if one person is submitting himself to some kind of treatment or program towards an underlying disease or a pathology. And assumes as well like abstinence of drug or substances as the ultimate goal. Under the banner of public health, this perspective is rendering drug users themselves as the ultimate agents of change, locating harm individually, but not politically or structurally, or at least sufficiently enough. For this reason, sometimes there is a bit of risk in this model of manipulating a rhetoric of agency to reinforce an idea that displaces a structural responsibility for health onto the individuals. There is a bit of a lack of balance in there. Although the medical framework has significantly contributed to healthier patterns of consumption and the quality of life of people who use drugs, still we are observing that oftentimes it's not sufficiently calling for an examination of how criminalization of drug use, for example, or other structural factors like poverty or homelessness are creating the conditions of vulnerability to drug-related harm and the influence on health outcomes. Another element that has been also arising is a psychosocial model that considers that a person's substance is shaped by a range of interrelated factors that are biological, psychological, as well as social. This multidimensional model focuses on identifying and responding the determinants of problematic substance use, focusing on ideas, especially of social learning. The two central notions of this view is that drug use is learned and that is also functional. And this model holds that substance use behavior is learned and reinforced by peers and puts forward a series of interventions that focus on altering the person's relationship with their environment. For example, one of the most common strategies you all might know is the so-called prevention strategies. In here, prevention strategies aim to address individual environmental conditions that foster substance dependence. However, as it occurs with the medical framework, sometimes psychosocial approaches still focus primarily on individuals and communities' responsibility as the site of harm and leave a tiny bit apart the social structures that contextualize, inform, and condition such behavior. The last framework that I want to bring in here, which is harm reduction, normally is understood as a movement of practices and principles that they are dedicating to reducing the harm associated to substance use in individuals and communities. As such, it encompasses both like a pragmatic series of strategies and approaches to provide responses to the needs of people who use drugs, and as well is a movement for social justice that is based on human rights principles. By emphasizing the social justice dimension, harm reduction is suggesting a much more systemic analysis of the complexity of drug use and is attempting to reframe where harm is located. Whereas medicalization, as I was mentioning, may turn situation into a bit black and white issues or symptoms that can be diagnosed and cured, harm reduction emphasizes a bit more of a complex approach to care. It's marking a bit of an idea from cure to caring. By focusing on care instead of on cure, harm reduction has developed in the last decades a series of interventions that aim to people where they are at. from needle exchange programs, opioid substitute programs, drug consultation rooms, alcohol consumption rooms, to name just a few. Henrik is going to focus a bit much more, and then he will give much more concrete examples. Harm reduction centers the needs, contexts, and realities and experiences of people who use drugs as the departure point, instead of a normative framework of what a health body ought to be, or a well-behaved body, or good citizen, or any other idea underlying the previous frameworks. As such, centering care through these lenses aims to develop self-sustaining practices and structures of mutual support that centers the capacity of people who use drugs to care for themselves, and the practices already exist, and empowers these practices to center leadership of the communities themselves in the development, implementation, and evaluation of the social and health programs they need. Through this gesture, and by centering the communities themselves, harm reduction through this social justice framework offers the possibility to critically analyze the conditions of people who use drugs that impact their health outcomes, and shows an alternative, breaking in this way patterns of stigma, shame, or isolation, and highlights how social problems result oftentimes from the maldistributions of resources as systemic problems, that is, that individual moral failings. That's a bit what I brought. One of the areas that I also would like to share with you with this is, like, when putting drug policies into practice, street level workers and workers that we are working on homeless shelters, oftentimes we need to be assuming and negotiating different interpretative beliefs coming from these frames that we have. In these negotiations, one of the things that we are confronted with is with contradictions that might arise. For example, when workers' beliefs and practices are different from those indicated on policy statements, or when workers with contradictory beliefs and practices have to work together. In these cases, workers might have some dilemmas regarding the activities involved. These different beliefs and practices maybe also sometimes getting in the way to build collaboration between workers in different services. For example, there is studies of how this in collaboration between police and health workers. So with this presentation, I just want to put forward in a very close way, like a question for you, or a different simple vocabulary to understand of, like, when you're working with drug users and people with drugs, what is like the views that you're having, and how actually what is the impact that is having, and what kind of relationship are you establishing with these people through these frameworks.
Thank you, Roberto. I think that's a very useful opening presentation in setting the frameworks and sort of the historical view of how those frameworks were developed, and also where we are now, what's working well, and how we can still influence those frameworks. I think that's really important. Okay, so we're going to, if you do have questions, please do put them into the chat box, and we'll make sure we put the questions to everybody. And then, but I'm going to pass over straight away now to Henrik Thiesen, who's going to speak from his experience.
Yeah, right. I'll just continue with the practical example of how we could work with the harm reduction. And
I think you just need to do a full share on your screen there.
Sorry. Is it up?
It's up, but you need to do the share full screen. So start from this slide, or.
Oh yeah, sure. So, yeah. So what I'm going to talk about is 20 years in 10 minutes, but it's also a bit about our travel through just delivering healthcare to implementing ourselves in a harm reduction system shared with a lot of other stakeholders in Copenhagen. So, see if it works now. So that what we had before 2005, I would say, was quite fragmented. It had been a bit more connected in the century before, but as it was in after the year 1999, everything was divided into different small clinics in different shelters. And I was hired as a medical doctor in a street project in 2001, and was actually localized in a different health center But over the years, we worked with the health outreach, and we looked into the health of the drug users and homeless persons we met in the streets, and found a very high number of diseases and very low access to healthcare, and only to acute and emergency healthcare. So that was a very low use of the one person in the Danish healthcare system who is the gatekeeper for the system as a whole, namely the GP. So what we found, what I found necessary to do that at that time was to try to establish a GP service, which were not based in a clinic and not based on set times for consultations, but would see the patients where they were. So what we could see was that the normal GP clinic wasn't available, and by that not being available, we could see that all the specialist care behind that GP in the secondary health system wasn't available too. So that meant that most homeless patients went to the emergency room, and the emergency system is not very good at keeping track of people. So normally health would be fragmented in that way also. So what we tried to do was to follow the social outreach work into the patients' housing, street, anywhere, tent, camp, or whatever, and work together with the social outreach to do exactly what a GP would do from his clinic. And by that, bringing the primary healthcare system into the homeless domain. Yeah, so it was quite simple. We didn't have a clinic, so we just focused on being available. And it actually started like this. This is from an article made a few months after we started. So over the years, we have built and on an existing body of NGOs and clinics and health professionals doing volunteer work and everything focused on health and just providing a better life for people. So we try to actually go into those sites and actually connect people with our own system, which actually it's not my system. My system is still 3 nurses and 4 nurses and 3 GPs, but we plug ourselves into those systems so that we will boost the different NGOs and drop-in centers with a healthcare ability. The network is based on us having a lot of eyes and hands all over the city. And we have tried to create a second primary healthcare system. So what we have made is a duplicate of the normal healthcare primary healthcare system, which is on the top. It's the GP practice. And we created a different variant of that, but without very much, without clinic, without fixed stations. And we try to plug into whatever's working, including the drug consumption rooms and the NGOs. And by that, being able to connect with the public secondary systems. So, because I came from the streets, actually, the first project started in the streets. I was able to navigate around in all these NGOs, making this Copenhagen city homelessness, help care, drop-in centers and things like that, but without ever communicating, or at least not very communicating very much. I needed to have the acceptance of everybody. So what came out of that was naturally that we had a harm reduction-based approach. We couldn't work with the Drug Users Union without having a harm reduction-based approach to drug use problems. And we worked together with people who were all focused on alleviating immediate problems. What we tried to do was to connect with that and then becoming able to take care of long-term problems in a continual relation. And what we could see that is that the more severe problems a person would have, the longer he would be attached to our team. But after 4 to 5 years, everybody would have dissipated into other settings. What we've also worked with almost in all years is involving user groups or user organizations in developing and distributing prevention and health. It has naturally been based on that daily interaction and agreement on the daily basics of health needs and individual self-determination. We are working with self-determined individuals which are by accident users of drugs, and we work with social workers and everybody else, and they're all equal in our collaboration. What we also have been doing from the beginning was that it's always been an absolute demand that we comply with the cultures of the individual NGOs. We come as health persons, but we also work when we are inside. We work as you would like us to do. Yeah. So I'll give you a string of examples from this. One of the first we did at all was developing a Naloxone Training pilot study with the Danish Drug Users Union, and actually kept that up for 6 years. And we went, as you can see, this is the Scottish prenoxide. We were among the first to use outside Scotland, and it has continued until now. We still work with the not in development, but we still work with the Danish Drug Users Union to keep this project going. One of the things that we did, which was actually very refreshing to do, it was that we saw a need for a crack smoking kit because things were changing and people were changing from injecting opioids to smoking crack and injecting cocaine. So we wanted to prevent hepatitis C from entering that group, and we developed this crack smoking kit in collaboration with the local drug users, as in a consumer survey, and with the Danish Drug Users Union, and they actually got jobs out of it, paid by the city to collect and assemble these kits. We've also done outreach, health outreach in drop-in centers to trace HIV, hepatitis C, and general health problems in all these years. And we try to do it at least 2 times per year and sometimes more often. The Naloxone Training has tried different methods to connect with the NGOs in the same way. This is from a football match for homeless, where the Drug Users Academy had Hep C. We're looking for Hep C, and we were training for naloxone, training naloxone, take home naloxone. We have done health outreach inside our drug consumption room. We had doctors stationed there for 6 months, not all the time, but in certain evenings we would try to get people to be PCR tested, and that just inside with a result from the test within an hour. Over the years, this health outreach has developed, and what we have done, at least until the COVID locked us down, was to develop outreach in combination with different NGOs. This is from our local city shelter, night shelter, and we are doing Naloxone Training. We have Hep C outreach from the Drug Users Academy, and my nurses are sitting inside the night shelter doing health outreach. So what we try to do now is to contact the different NGOs and say, and set up a whole day of health outreach, also based in the local needs. This is from one of those. It's a health clinic in Christiania, and the nurses are inside doing the setting up a clinic, and I'm on the first floor doing Naloxone Training, and the Drug Users Academy are outside looking, trying to connect people with.
Just
yeah. Sorry,
yeah, just if we could finish up there, Henrik.
Yeah, I will do that. Right now we're doing vaccine outreach, and we're doing that the same way. We're working with the local NGOs, local shelters, and we're setting it up via those institutions and NGOs. So they will call for people to come to the vaccination sessions, and we will be there setting up a vaccination clinic and being ready to take whoever might come through the doors. And right now we have also reversed it a bit, so the Drug Users Academy has moved into our local nurse clinic at Sundholm and is performing hepatitis C outreach. So that's it. Thank you.
Thank you, Henrik. And with that, just responding, I'm going to pass over to my colleague, Karen Feeney. Karen, thank you.
Hello, and that was just really interesting to hear from, I suppose, Roberto and Henrik, and I suppose that piece about sometimes I think that, yeah, the frameworks that we can have around harm reduction, thinking about it for today. I suppose harm reduction, I often think of it, it's kind of, it's the opposite to homelessness. As Roberto talked about, sometimes our response to people can be that their actions, whether drug taking or poor self-care, are kind of our personal choices. But in an organization such as Simon, we are working with people who are the most excluded, and there are these very difficult intersections between homelessness, addiction, and poor mental health. And we know that these are very often driven by poverty, trauma, and violence, and that people can't always meet the requirements of services that are asking them to abstain from substances or to engage in prescribed ways. So, you know, a lot of mainstream services can be miss 2 appointments and you're out, or complete the form incorrectly and you need to go to the back of the queue. And things like Simon and harm reduction approaches then are about trying to engage with people exactly where they are at. I think, as I suppose I'm also kind of what we can see from Denmark and some of what Roberto has talked about, that very often harm reduction responses were very much peer-led initiatives. So if you think the bit about thinking about the number of years we are in these working in this frontline, you can think back to a time that there would have been a lot of opposition to opioid substitution therapies like methadone clinics, or even earlier during the AIDS crisis, some of the initiatives to protect people's sexual health would have been kind of almost objected to on very kind of moral basis. And things have evolved a lot, but it is understanding that these peer-led responses were about reducing the harm, keeping people safer, and really keeping people's dignity at the center of any initiative. And I suppose, again, that this is where homeless NGOs have a very important role in terms of kind of meeting people and working with them in a way that puts their kind of dignity at the center. I think the people always have very complicated relationships with themselves and with their own health. And if we, I suppose our endeavor has to be that they do not kind of lose shelter or get further excluded from society because they're not kind of conforming with the basic rules. But I suppose I'm kind of interested in what we're kind of seeing from Denmark, because sometimes it can feel that you are in the NGO sector, and it's that the work with other stakeholders who are kind of providing services, and how can we have a greater response. I think the thing that Henrik has described is the building of a very alternative kind of primary care system. And I don't think we have anything, we certainly don't here in Galway, and I don't think we have anything similar to the kind of organization of drug users themselves. I mean, I think it was kind of quite interesting, the projects around the crack pipes as an initiative to reduce hepatitis C, but that that this is kind of an initiative that there is kind of organization, and I suppose I would be kind of curious about kind of how that is supported and how that is different. I think from our experience here in Galway, like initiatives like Housing First, Community Detox, the widespread kind of use and training and promotion of naloxone amongst drug users are very important harm reduction initiatives. However, there is kind of at times when we are working with other stakeholders and maybe the more mainstream health services, that it's kind of persuading and bringing things kind of around to our kind of point of view, because sometimes there's kind of can be absolutist requirements. So I think that's kind of a kind of important note in it all. How we support other that all institutions can take on a more can embrace more, I suppose, the harm reduction philosophies, and that we are kind of seeing this coming into other areas, not just simply and exclusively health. Things like Housing First are about meeting people where they're at, providing that kind of that security, allowing people to be safe first and foremost. And I think there is this. I think what's very good about this talk for us as practitioners, again, I think sometimes it grounds us in what we do, that we've all been in. I think many of us have had those moments where we're supporting somebody, and it's whether it's an emergency hospital or whatever, and it's like, well, where are they getting the drink? Or there's an accusation sometimes that you can be enabling or fostering or supporting kind of behavior that is harmful to a person. But we know, again, that it is working to keep people safer, working to help people make the best choices that they can within the circumstances that they are in, and then working kind of at a greater level to maybe ensure that structures and responses are much fairer is what we can do. But it is remembering, I think, that thinking about kind of people's safety, thinking about the ways that we reduce harm, doing the best that we can to ensure that people's health doesn't deteriorate, that people's circumstances don't deteriorate, that their ability to move along a continuum and to do things on their own terms is really, really important. And we have to find ways to invite more of the mainstream to understand this. And I think we have that evidence from a lot of initiatives both around Europe and the world, particularly things like housing first, trauma-informed care, and what we have learned from harm reduction responses to people engaged in drug use. I think I have come to the end of my allotted time, have I? Am I reading my clock wrong?
That's actually a very nice place to start, because I think part of what today is about, I suppose, is sharing the learning. So I'll invite the other speakers to come back, and we might just build on that theme then, because there's a couple of questions have come in. So one directly for Henrik, which is, could you tell us a bit about how COVID has affected your approach to harm reduction? And I'd also add into that, I know there'll be a lot of interest about the rollout of the vaccine into the homeless and how we're dealing with, or what you're seeing and how you're addressing in terms of any vaccine hesitancy maybe in the homeless population.
I don't think I've changed at all in regard to harm reduction in these COVID times. We've tried to build a system from the beginning where we could isolate people and still keep get them into substitutions treatment almost acutely in the isolation facility. So we've tried to build testing, isolation. Actually, we've managed to get people into substitution treatment from isolation facilities, so that if they were presented with the possibility of for instance, getting methadone when they were released from the isolation facility. And we have seen a lot of new, very close handheld outreach types from the drug treatment system, which works very well with what we have done. So with the vaccines, we work with the local NGOs. Of course, we have to take what we get from the hospitals, from the local regional hospital system. They provide the vaccines, and they provide the rules for who we can give the vaccines to. But finding the people who are eligible for vaccines and setting up a session that's local NGOs, and we plug into that. And I will normally come a day or two before, and we arrange where to sit and how to do things, the logistics around it, and do that so everything works smoothly. But we are not directly engaged in getting people into vaccines. So we see a very low hesitancy against vaccines. But the more, the better functioning groups are actually have a larger hesitancy than the more marginalized groups. The more sick people are, the more they understand they need the vaccine. But people who are not, who might have mental problems with the what do you say, stories around vaccines, where you
conspiracy theories kind of things.
Sorry?
Conspiracy theories that are coming up.
Yeah, conspiracy theories. They are flowering also, but it's very often it's people who have conspiracies and everything. But normally we see that people come back when we come for the second vaccination. Some of the ones who were not there for the first and didn't want it at that time are coming to have their first vaccination at that time.
So you're seeing that process of people sort of learning from their peers.
Yes,
When
yes.
the peers are getting it and they say, okay, there's no side effects. And then,
Yeah, and we try not to push, because if you try to push people towards doing something in that setting, it would be counterproductive.
Okay. We're coming to the end of our time, but I do want to ask, Tony Duffin has put in a question here as well, which I think is very pertinent to harm reduction, because Karen made the point that some people believe that harm reduction facilitates drug use rather than necessarily addressing it. However, he makes the point that if harm reduction is not delivered appropriately, those services are in danger of veering into harm observation or worse, harm promotion. What needs to be in place for harm reduction service providers to avoid this happening? And I'll just if you can give me like I'll give all my panelists a chance, but if you can get it to like 40 seconds of an answer, then apologies for the shortness, but we're coming to the end. And Roberto, maybe.
Okay, I'll do my best on a 40 seconds to reply to that one. I think it's like, yeah, once more, I think like the use of the words is like belief that harm reduction facilitates drug use comes back into these ideas of what are the frameworks to which we are looking at the phenomena that happens, because harm reduction in itself does not facilitate drug use, but facilitates healthier approaches or safer approaches to have a relationship to drug substances. And itself that puts a bit forward like the idea of harm reduction services, of having also the privileged position that sometimes is not understood completely, of providing evidence of actually the effect that harm reduction is having. And evidence is not always the scientific knowledge to be able to provide data what's happening, but also the communities themselves having the capacity to testimony of the improvements in the qualities of their life. And that's already in itself, like building on this idea of evidence as contrasting beliefs, that is still is like something that harm reduction services could build upon, because everybody that is working in harm reduction services clearly sees that it does work and it does improve the quality of life of people who use drugs. That's 40 seconds.
Thank you. Henrik?
Well, I think everybody wants to do well. The basic thing is that everybody wants to do what they do, but they want to do it safely. So and if you try to change people's behavior just to comply with your own rules, it will never work. But of course we can see something developing, for instance, from the immense crack use we have in Copenhagen. We can see people actually engaging in much more harmful procedures than they did when they were using, or the prior groups who were using heroin. And that's a bit hard to because we have to build it from the beginning. New harm reduction methods to actually take care of that group, and so it's building the building while we are doing the work actually.
Okay, thank you. And Karen, do you want to answer your own question?
Well, I think it's more I think that's I think the piece kind of about, you can feel, sometimes, yes, we don't always agree with the choices that people are making, and sometimes it can be hard to observe where people's health is deteriorating despite your best efforts. But it is that focus on, I think, the dignity of people. I mean, I think yes, good practitioners bring a lot of skill, things like motivational interviewing to try and help sort of change. It's not that you're standing back and saying we can't do anything, but the autonomy of the person. But there is a tension in that. And I think it can be difficult in teams, and we possibly don't kind of talk about that enough. And sometimes we can be frustrated with each other. And that's within a sector that engages in harm reduction. And I suppose, and that's what I was kind of trying to touch on as well. But sometimes you are also trying to persuade, not alone, we can have difficulties in-house, and then you're also trying to persuade and advocate for this approach outside it. So I think it is about skill and it is about nuance, but it is, I'm firmly of the belief that harm reduction is the opposite to hopelessness. Because if you say, if I am engaging with you, I'm facilitating you, then you really are leaving people, you know, that's how people lose shelter, lose any kind of protection because of problematic behaviors or drug use. So that's my 40 seconds, is it?
Okay. Thank you very much for everyone. We've run slightly over, so apologies to our attendees. I hope you found that interesting and useful. I know I did. And obviously we'll be emailing you in future with future Simon Talks. But thank you very much, everybody, for your time, and we'll finish it there. Thank you.
Thanks a lot. Bye.